All right, well, maybe we'll get started. I'm Margie Wheelock. I'm a plastic surgeon here in Halifax, Nova Scotia, and I'm going to be the moderator of tonight's session. I did start by introducing our panel, and we have a great group of surgeons with us tonight from across the region. So from Newfoundland, we have Dr. Joy Cluett, and from New Brunswick, we have Dr. Susan Skanes and Dr. Ian Maxwell. And then from Halifax, we have myself, Dr. Jason Williams, Dr. Marty LeBlanc. And then we also have a breast oncologic surgeon who's joining us tonight as well, Dr. Lucy Hellier, for any questions from that perspective. Also, Carrie is with us tonight from the Canadian Cancer Society. She's a senior cancer information specialist and can help us if there's any supports that they have to offer as well. So our panel tonight, we have 45 minutes to discuss breast reconstruction in the Atlantic provinces. It's a chance for you to have any questions that you'd like addressed, and hopefully we can give you region-specific answers or information. So welcome. Please feel free to put your questions in the chat. This is your chance to ask us any burning questions that you have. We do have some questions that have been submitted from the platform, so from across Canada. So if you don't have specific questions, we'll start with those, but please feel free to add things as we go. Also, if at the end, if you do wish to leave, if you want to go see other panels, please feel free to leave and join another panel, or leave and come back. Like I say, it's 45 minutes, and we'll be here for that time. So Dr. Cluett, maybe you want to talk, there's a question of how safe is reconstruction, and is it possible for my breast cancer to come back due to reconstruction?
I think everyone is, as everyone is aware, breast reconstruction is very, very safe. I mean, the only instance I think when it may be an issue is the implant reconstruction, if you were to get a recurrence behind the implant, which is very, very rare. As for does it cause cancer to come back, there's definitely nothing that I'm aware of in the literature that would suggest that it does. Anyone else have anything else to add, other than the fact that the reconstruction itself may hide something? But I mean, I think we all know that it's a systemic disease by nature, so the reconstruction wouldn't have anything to do with the reoccurrence as such.
I mean, I'll chime in as far as safety goes, Margie, if that's okay. One thing I always tell my patients, I mean, I go through a big list of potential complications that can occur with reconstruction, and I guess my line is sort of, the only way to avoid these complications that come with reconstruction is to not have reconstruction. So certainly there's some risk benefit that comes into play, but certainly in terms of comparison to other similar surgeries of similar magnitude, I would definitely say it's safe. That would be my answer to that question, with the caveat that there are, of course, expectations that need to be sort of set, and risks that can occur that are unique to breast reconstruction.
Certainly, Margie, I'll chime in here. From an oncologic point of view, there is no, there was no risk for increasing your risk of breast cancer. And I agree, same with Joy, that there's apart from that very, very rare instance where it comes behind the implant, and it's extremely, extremely rare.
Thank you. So we do have one question from our group. Maybe Dr. Skanes can comment whether you can have a mastectomy and reconstruction at the same time.
It's quite common now that we would do it at the same time. If it is indicated, according to the oncological surgeon and the medical oncologist, radiation oncologists, it's a very good way to proceed in the proper patient. And it can be done at the same time as a first stage, or it can be done at the same time as a straight to implant. So I would say half of the breast reconstructions that I do now are in fact immediate, which means they are done, or at least they are started, for instance, with a tissue expander at the same time as a mastectomy.
Dr. Hellier, do you want to add anything to that from your perspective?
Sure, Margie. So I think that Dr. Skanes, is right. So the right patient, right disease, certainly direct implant or direct reconstruction is a great choice. There's lots of things to consider from an oncologic point of view. As they've mentioned, do you need to have radiation? Will you need to have systemic chemo? They all have to be taken into consideration and discussion with the multidisciplinary group, that being the radiation oncologist, medical oncologist, and the plastic surgeon. But certainly if all of the stars align, then that's definitely the approach we try to take here in Halifax.
Thank you. So we have another question. Maybe this one might be region specific. So I'll get Dr. Williams to chime in first and others can add. But this is someone who would like to have their reconstruction and mastectomy done as soon as possible. They've been waiting for surgery for more than a year, and they're wondering about the timing for operation.
Thanks. Yeah, I'm going to maybe separate the question a little bit because oh, it disappeared. But I think if you're waiting for a mastectomy, I'm going to assume that means it's a prophylactic mastectomy, because if you're waiting for mastectomy for a year for cancer, then there's something wrong. So if it's for prophylactic mastectomy and reconstruction, unfortunately, in our region anyway, there can be excessive waits. And it's just a function of our resources, both in terms of plastic surgeons and hospital resources. If you actually have had your mastectomy and you want your post-mastectomy reconstruction and you've been waiting for a year, that's sadly a common situation as well. And there are often two or 3 or more year waits for that. And none of us like that. We don't want people waiting, but it's something that's beyond our control. And we would encourage people that are waiting to advocate with the people who control the resources, i.e. politicians.
So I think there's a follow-up saying that there's been a mastectomy on one side and they're waiting for the contralateral prophylactic and reconstruction. But I would echo that. I mean, certainly in Halifax, I know we've been affected by COVID and now nursing shortages. It's been really, really frustrating. Dr. Cluett, do you want to add to that?
We've been really affected by that here since the beginning of COVID. I mean, initially it was COVID, but now it's because our beds are blocked by long-term care patients waiting placement. So we're having great difficulty. Obviously, it's always difficult to coordinate with the general surgeons for the oncological part of the surgery, but in terms of anything requiring an admission, it's been really difficult. We're definitely down on the priority scale.
Yeah, Joy, that's the same in Halifax. In the last few months, we've experienced that. And so we can't do the bigger operations right now, which has just increased the wait times that much more.
Yeah.
So in Moncton, just to give you an idea, it's the same with COVID bed situation. So if you're waiting for an elective mastectomy, it's in my city, you're probably going to wait 8 months to see the surgeon, and then an additional 6 to 8 months to have your surgery. So it might be a little bit better here.
I don't know, Ian, if you can speak to what it's like in St. John.
Yeah, we're having a problem like everywhere with a nursing shortage in our OR, and that's probably the biggest factor right now, actually even more than COVID. We're operating half the number of rooms, so I haven't done a DAP, a free flap for, it's been a couple months now, actually, month and a half. So for us to get, they started canceling late days here. So obviously, like you've had in Halifax, it's been pretty hard to get big cases done. Smaller ones and implant-based reconstruction, yes. But then also there's the issue of coordinating with general surgery when time has already been cut for both services. So it's not a great time for timing. But I would say our wait lists are probably shorter than, I know West, shorter than out West. But I think probably mine would be, I imagine for, a non-cancer operation, 8 months to a year, like Sue was saying. Yeah, pretty similar, I'd say.
Yeah, it's certainly been frustrating. There's a follow-up question that maybe it's easier for Dr. Hellier to answer. Is would it be quicker to have the remaining non-cancer, the breast, removed while waiting for reconstruction? So whether to go ahead and have a contralateral prophylactic mastectomy while waiting.
So yes, and it's partly because that surgery can be done as an outpatient, and so the lists for outpatient surgery are often shorter. So I think that on my wait list, you're waiting about probably under a year, 6 months for a simple mastectomy. And then I don't know what your weight is for bilateral reconstruction then, but it certainly does take out the coordination part of it. And I don't know if COVID backlog is going to, to open up. So that is one of the options.
Great, thank you.
Dr.
Certainly would change. Oh, go ahead, Dr. Moons.
I just had a thought on that. Just I don't want to hog any of the floor here, but one of the struggles we have as plastic surgeons is obtaining symmetry. And if I have a patient who's really worried about their cancer risk on their contralateral side, which, as we've I think heard and understand, it's not, unless you're gene positive, it's not significantly increased, but there's a lot of psychological impact. So to start to try to get symmetry on an immediate reconstruction on one side and delayed on the other side, it's challenging, a little bit more challenging sometimes. So I'm never too upset if someone goes ahead and has their second mastectomy done and then comes in with a sort of symmetric foundation for us to start with. But I'm not sure if the rest of you feel the same way.
All right. Just there's some participants who have joined well after we started. I just want to encourage, if you have questions, please put them in the chat. We are more than happy to try and address them. So please feel free to put questions in. While we're on kind of prophylactic mastectomies, oftentimes patients with gene positive or high risk patients are younger. And there's a question of whether sorry, I just lost this here. Okay, whether having breast reconstruction in your mid-30s increases your risk of needing further surgery, and if that might impact your choice of reconstruction. Maybe Dr. LeBlanc, do you want to speak to that?
Sure, yeah. I think when I meet patients, we do talk about all the options, and then some of them will have a good idea of what they want or what they might want. I do find that people are living longer nowadays. So people are, you're 35, you're really, really young, and there's a good chance you're going to be living for the next 40, 50, 60 years. We do know that using your own tissue 15 years down the road is probably going to lead to more patient satisfaction. So if you looked at 1,000 patients 15 years down the road, if they use their own tissue, they're a little bit more satisfied with their reconstruction than an implant reconstruction. And I think I would always advise my implant reconstruction patients in their 30s that there's a really, really good chance that they're going to need a second operation at some point. I have a hard time believing that those implants will last 60 years, but who knows? Some people are sometimes worried that you have to change implants every 10 years. That's not the case. I think implants are going to last a very, very long time. And I think on an individual basis with your surgeon and doing a bit of research, that I have a bit of both. I have patients in their 30s that go on and have implant reconstruction. I have a bunch that use their own tissue. I think if you use your own tissue and you get it right the first time, that probably will last forever. I have a hard time believing that the implants will last another 60 years until you're 90. So you might need a second operation, but a lot of the implants operations are really, really small. You go home the same day, quick recovery. So I'm not too worried about having to do another surgery at a later date in time.
Dr. Hellier, can you speak to whether the gene ATM has an impact on breast cancer?
So the ATM gene has been linked with an increased risk of having breast cancer in the future. It's not as high a risk as if you are BRCA positive. And the recommendations for the exact risk, your lifetime risk of having breast cancer are somewhat spread across sort of like 25 to 60%. So there's no real defined risk. But in my patient population, ATM has been an indication for prophylactic mastectomy. I generally follow these patients with yearly MRI and mammograms, and they are seen by one of the plastic surgeons for consideration.
One thing, we were talking briefly earlier about the idea of having your prophylactic mastectomy while you're waiting. What would, I guess, maybe Dr. Skeens, you could say how having a one-sided, so a unilateral reconstruction impacts your decision-making versus both sides?
So that there are so many things that are going to affect that. There are some women who have the perfect breasts to match. They're not ptotic, they're medium size, the nipple areola is in the right position. I mean, these ladies, they can have a unilateral and have very good symmetry with an implant. If you're talking about a woman who is very ptotic, her breasts are hanging very low, you are not going to have symmetry with an implant reconstruction unless you do something to the other side. And there's a lot of conversations to have about the other side, sometimes more than about the breast that's being reconstructed. Do they want it higher? Do they want it smaller? And I think we have to be very, I'm always careful to be respectful of a woman's healthy breast. I think some women I see, older women usually, even though we may see as plastic surgeons that they don't have symmetry or they won't have symmetry, some of the ladies who are older, they want to keep their native breast if they don't have an increased risk or genes that are put them at increased risk. They have a native breast with normal feeling and they don't care really if out of a brassiere, if nude, they are not matched. So I can't answer your question. There's too many variables involved. I think overall you'll have better symmetry with a bilateral procedure, but I do not suggest a bilateral procedure. There are many reasons not to suggest it, put it that way.
Margie, I would just add that it's pretty rare nowadays that we're not doing some type of procedure on the other breast. It could be very minimal or it could be very invasive, like a total mastectomy. So I think understanding that it is hard to get symmetry, but it's really, really rare. I would assume in most people's practice not to touch the other breast. Again, it's your choice and people's choice. But when I look at my practice and my patient population, I think the majority of our patients will get some type of balancing procedure on the other side. So I think just something to keep in mind and understand that we can help with that too.
I got to agree with
Dr.
Marty
Clear?
there. I very rarely do nothing to the other side. And I don't know about you guys, but I do find, and maybe Lucy, you can talk more about this, but even when they do simultaneous prophylactics, they're never as aggressive with the prophylactics as they are with the mastectomy, the modified radical. So you always end up doing something with the prophylactic because there's more tissue left behind than you anticipate, even if it's, I guess you don't need to. So even that is not the perfect situation, even if when it is simultaneous, I don't mind. But.
Yeah, I would agree, Joy. I noticed that in my own practice that we probably leave a little bit more in the lateral aspect. We haven't gone up into the armpit with a sentinel node. So it never sits quite the same, even though I map out my incisions and everything.
Another question about wait times. It's certainly a hot topic right now, which is fair. I will just leave this for whoever wants to jump in, but are these wait times based on provincially funded programs, or do we have a choice to pay to not have to wait years?
I'll jump in, Margie. So it's a bit sad maybe, but you can pay for all kinds of stuff in your life, but you can't go and buy a breast reconstruction. And it's a provincially insured procedure across the country, as far as I know. And I think we are all part of the Canada Health Act and the Nova Scotia or whatever province you're in, health services insurance, and we have to be party to that, and it's probably illegal to charge or do it privately. Anybody else know any different?
Yeah, so in my province, we have an opt-out clause, and we can't do anything that is covered by Medicare on a private basis. Understanding that you still need to use the resources that one would use if it was covered by Medicare, unless there is a plastic surgery private clinic with a general, with an anesthesiologist. And in fact, in Moncton, I think that's going to happen. It's not my clinic, but if that does happen, and if there was someone in New Brunswick who wanted a breast reconstruction more quickly in this province, you could go right ahead and have it done privately.
I'm surprised, Sue.
Yeah. You have to tell the patient, you have an onus of advising the patient. I'm aware of this too, because I was on the college. So you have an onus to tell the patient that it is covered by the provincial system, and give them options of people that they could go see to have it done privately, to have it done funded by the government. But no, you are perfectly able to do it under privately. If you can find a surgeon who has a general anesthesia in his office. Now, we could also take time in the hospital's ORs to do private surgeries, but I personally would never put a private case before a Medicare case just because there's more money involved. So I would say if you are going to have it done in a hospital, even if it's private, you're going to wait a lot.
Yeah, I'll just add to that. I know when I was working in BC, there were people who were doing breast reconstruction at the private clinics there at Cambie and ASC in Vancouver. And the legality of it, I'm not sure. I know there have been some court cases since I was in BC that may have changed that. But it was being done when I was there. To answer sort of a short answer, it was being done. So
the other option too is going to the States, right? It might not be a perfect timing right now with COVID, but you can always go there too. There's private clinics, reconstruction.
I'd like to say though, for the women who are listening who are waiting, if you're past your cancer, if you have had cancer and you're past that stage, or if, let's just say that situation, you've had your cancer and you're past that stage and you're waiting for reconstruction, it's usually a wonderful road. You may have to wait for it, but in the vast majority of patients, I'm the elder on this panel. I've been involved in this kind of surgery for 35 years. And I have yet to see a patient who, barring any complication that sets back, is not thrilled at the whole process. So you have something to look forward to, and it will happen. But patients are thrilled with the process, generally.
All right, well, we have a couple of questions. I think they're probably more for Dr. Hellier. So the first has to do with the type of mastectomy and whether the contralateral prophylactic, so having your mastectomy on the other side, should be the same as the original side, since the first side will need an expander. I guess that's a little hard to answer since we don't know the exact type, but Dr. Hellier, I'll pass that over to you.
Okay. So my interpretation of this is, so they had a non-skin sparing mastectomy on one side, and then now we're wondering whether or not they should have a nipple sparing or a skin sparing mastectomy. So actually, I'm going to bounce that back to the plastic surgeons, because I think this is all about aesthetics. Because from an oncologic point of view, if they're not BRCA positive or gene positive, then from my point of view, it's all up to how you want them to look and which would be the best way to reconstruct. How's that?
That's fair. Dr. LeBlanc, do you want to chime in then?
I remember, I can't remember who the residents were, but we had students that did look at that study and then ask patients, would you rather have a skin that looks different on one side than the other? and then keep most of your skin on that one side. It was 50-50. I think it's a patient preference. Sometimes they'd rather keep this, depending if the skin envelope is in good position, whether you want to save the nipple on that contralateral side. There's been occasions that we've done that, and then say the other half, we've just completed the mastectomy as it was on the cancer side and try to match it that way. So I think it's just one of those conversations that you want to have with your reconstructive surgeon and your general surgeon, and then come up with what you both think is the best for you. So I think either way is fine, and we'll do what is best in that particular case. So.
Right, and then there's another question about having a triple positive breast cancer that was treated with chemotherapy, mastectomy, radiation, and then chemo, and is now being asked to do target therapy. And the woman's asking if I can still have surgery to have the other breast removed preventatively, and then have a double reconstruction.
I think that, the targeted therapy, Herceptin, which I gather is the treatment. There is, we often, there's no, what am I trying to say? There are no barriers to operating when they're on Herceptin. So when you're taking the kind of targeted therapy, there's been no anesthetic risk. However, Herceptin does have certain effects on your cardiac status. So they would all have to be taken into account with the anesthetist. Oftentimes we like all of the treatment to be finished before we start that sort of like large surgery. With the newer medications coming out, the immunotherapies, I also do melanoma. So we often do surgery when they're on immunotherapy for that point of view. And it really doesn't seem to affect their healing times or complications for that. But I think that also would be a conversation for the plastic and the reconstructive surgeon, because you're the ones who are looking after the complications and knowing all of the risks with respect to implants and tissue transfer.
Yeah, I guess I would go to the broader group. Then are people stopping Herceptin before doing pre-flaps, such as a DIEP? I don't think we are as a whole. I think that, for most of us, we're still going ahead with it. That's my personal thought. But
yeah, I think sometimes it's been stopped by somebody else. Like they'll go to the pre-op clinic and they've seen an anesthesiologist, and the pre-op clinic will have stopped it, but it's not routine practice for us to stop it.
All right, we have a couple more questions. So Dr. Maxwell, can you speak there to BMI restrictions with a DIEP? So this is a patient who has a BMI over 40 and was told that she's not a candidate. And why is that most surgeons would have a BMI limit?
Okay, I think that's a question that varies depending on what surgeon you speak to. And that's okay. For me, I'm a little more liberal for sure in my BMI requirements. And I don't think BMI tells the whole story either. Like I've had patients who are bodybuilders and their BMI is high and they're not unhealthy in terms of high BMI. And so I don't just, some surgeons I know just, won't even see the consult. They, they'll get the referring person to put, the BMI on, and then they'll say, oh no, if your BMI over 30, I'm not even going to have you come in my office. And that's definitely not me. I'll see anyone in the office. I don't need to know that before. I like to meet the person and see what their other health factors are as well. That's probably more important to me. Certainly high BMI on its own, no, not a contraindication or a reason not to do the surgery for me. I think that would be supported by the evidence. Certainly amongst my fellowship supervisors, I know, again, there's a huge difference, and some would, some wouldn't. And I think that the people that tend to allow higher BMI patients get totally satisfactory results. And I think it's also an issue of patient autonomy too. I mean, I explain to my patients that surgery might be more difficult. Some higher rates of complications might occur, but I still think it's up to the patient to make the decision and to be okay with that. And if they want to take the time to get more fit, then again, that's fine too. But I typically don't restrict BMI, or I don't have a harsh cutoff, I guess. Now there certainly is a point where I would say, okay, it's too much and the surgery is not safe, especially in combination with some other things that may happen like diabetes and whatnot. But no, to answer simply, no, on its own, BMI is not a reason not to for me.
Margie,
Yes.
if I may address implant reconstruction with high BMI, from my perspective, I see everybody who is going to have a prophylactic or wishes a delayed reconstruction, no matter what their BMI. And although with certain other procedures like a breast reduction or an abdominoplasty, I may wish not to operate because of complications, I don't feel that, I feel like I have to try to do the reconstruction because of what they've gone through. And that's how I feel about it, barring any other comorbidities, of course, heart disease, diabetes uncontrolled, as Ian said. But there's one thing with implant reconstruction with someone with a high BMI. Implants are not made big enough yet. The companies are talking about making them bigger. But if someone is 250 pounds and stands 5'7", the largest implant on the market today in North America will only give them a B breast. And that's because it kind of blends in with the rest of the very thick chest wall abdomen. So that's a bit of a limitation for any of you ladies who are waiting to see someone for breast reconstruction, and you are heavier. That's something you could think about. To have a good result, which is in proportion with your body, from a implant reconstruction is a little bit difficult if you're very heavy. And everybody feel that way, or anybody feel differently?
So your comments are on the money with what the literature would say, which is that with patients that are overweight, using your own tissue is generally more satisfying when it works, but we know the chance of complications goes up a lot with wound healing and so on when people are really overweight too. So it's as Ian said, it's a discussion to have and weigh your risks and benefits. But it's not truly an elective surgery that we can turn somebody away from easily, because it's your heart goes out to people that are going through this and you want to help them. But I think we've all stretched our limits on who we think are good candidates, and we've dealt with a lot of complications as a result.
Okay, a couple more questions. We're in the sort of last 5 to 10 minutes of our panel. So what are the steps for a patient before DIEP surgery? So are there any tests that should be done, or such as an MRI? Dr. Williams, do you want to take that?
Yeah, there's not a lot. The only test that is sometimes done is what's called a CT angiogram, and we would generally only do that to help plan to see if there's adequate blood supply to the tissue that we want to use. And it's applied variably. Some people use it all the time. Some people use it for certain situations, like when there are scars on the abdomen that may have interrupted some of the blood supply, the little perforators that we rely on to nourish that tissue. But that's about the only test that is often or sometimes used that I can think of. Anybody else?
I mean, I guess if you're if you're a BRCA and you need regular screening, then you might be having MRIs. That would be the only other time, I think.
From a breast cancer point of view, yeah.
I believe that there's someone who has their hand raised. Unfortunately, we can't see it. We actually can't. Well, I can't see it. And we to maintain anonymity, we just ask that you put your question in the chat, and we will try to get to that. On the same line of having previous surgeries on your abdomen, for patients that are not candidates for a DIEP because their abdomen is being used and they'd like an autologous reconstruction, so they don't want a latissimus dorsi. Are any of the group doing those surgeries, and would you recommend that if it's not done in your region that the patient be referred out?
I mean, I'll speak for me in New Brunswick anyways. Yeah, I mean, I've never done an SCAP, a buttock flap for breast reconstruction. I didn't even see one in my fellowship. So I probably wouldn't, having never done it before. And I'm usually, when I see patients, if I haven't done an operation, I'm always honest about that, and tell them, listen, I've never done this before. And so for me, yeah, it'd probably be a refer elsewhere if they didn't have adequate abdominal tissue for whatever reason.
I've tried to refer elsewhere, actually, patients that have specifically asked for that procedure, and I've had difficulty getting referrals outside the province, but it hasn't worked out.
Difficulty getting the province to pay, or having them be seen?
To be seen. Yeah, there's definitely been a difficulty in having them be seen.
Yeah, there's no one in Moncton who is doing that.
Ontario, I think, Ontario and Montreal are probably the closest you're going to get, but I have had trouble sometimes.
Yeah, we had a patient that went to Manitoba for autologous tissue transfer.
Yeah, I'll throw out, Margie, that in my 15 years now of doing this, I can think maybe of only one patient I haven't been able to satisfactorily reconstruct with our 3 most common methods, which are implants, latissimus implants, or DIEP flaps. And those other flaps are way down the list because they're not as good, and they're complex surgeries, high complication rate. And the buttock flaps, I've done some in fellowship, from fellowship years gone past, but it's very dense tissue too, and makes a really hard breast that's hard to match the other side, from my experience. So it may sound cool, take a little extra tissue from the buttock, but it's quite deforming down there, and it doesn't make a great breast. But if you're active and you don't want your shoulder affected at all, maybe it is the best option for you, but it's not a panacea.
I think it's worth mentioning that the donor site from latissimus dorsi flap is not bad. And I know people still climb, they still row and lead active lifestyles and play sports afterwards. So I think that's to be considered too.
I gotta say, for us here in Newfoundland, latissimus dorsi is becoming a much more popular flap than the DIEP. I can't remember the last time the DIEP has been down here, but we're doing many more flat dorsis, and they look really acceptable, I think.
I think some of my best looking reconstructions are latissimus with implants.
Me too.
Now that's before we started doing nipple sparing mastectomies, though. They just look great.
All right, well, I think that we are wrapping up. I was hoping to talk briefly about implants. I know lots of women have questions about implants and their safety. I don't know, Dr. Cluett, do you want to see if you can say something quickly on that? I didn't give you much time.
I mean, I think to date, the safety is pretty much documented. I mean, there was some controversy there for a while because of the breast implant associated problems with textured prostheses. But I mean, I haven't heard anything of late that has sort of signified that it's become more of an issue. And I think I feel comfortable telling my patients they're very safe to use.
Yeah, I think that's fair. It tends to be a relatively long involved discussion, and probably a great one to have with an individual surgeon. So I think we're all happy to chat about that when we see people in our office.
I always bring it up these days because everyone is on social media. So I always tell them about the past controversy related to the implants, but I do reassure them that it wouldn't stop me from using them.
Reductions, doing a breast reduction safe after a mastectomy. 1 minute.
Is a breast reduction safe after a mastectomy? So lumpectomy, sorry. Yes, yeah. So a lot of lumpectomies have radiation. It's the radiation that scares me. I am very hesitant. I think 15 minutes is spent on your skin may not do well, your nipple may do well, it may harden your fat, but all in all, I would have to say it is 70% safe. As long as we're not trying to move things too much in one direction or the other, we can do wonderful things with indented lumpectomy scars and nipples that are not in the right place. Yes, I think we can, but you're not going to get a perfect result. You're not going to get, usually if you're radiated, you're not going to get a breast that looks exactly like the other side. But we can make it look much better 70 to 80% of the time. Yes.
And I don't know about you guys, but I find that any breast that's been irradiated, even if their skin looks perfect, the times that I've done it, they get an incredible amount of fat necrosis that's long lasting. They take a long time to heal.
My experience too. Yeah.
Yeah.
I agree. I've almost stopped doing it for that reason.
Me too. Me too. I mean, I remember one lady, she looked perfect. She was 20 years out, and I thought, no problem. And she was in pain and agony for months.
So I've started trying to coordinate with the general surgeons and do lumpectomies as a reduction pattern, do an oncoplastic pattern reduction. It's just the coordination is difficult, and you've always got to hopefully do it before, obviously do it before radiation, but it's worked nicely.
So I would say,
Very cool. I think we have to wrap up.
okay.
Sorry.
Okay.
Thank you to all the panelists. It's been a great discussion. We appreciate your time, and I'm sorry I had to cut it off. If you have questions that were not answered, please reach out to the Cancer Information Helpline. Thank you, everyone.